So welcome everybody to another problem-based learning session. We've got a new case today. Let me share with you the initial presentation here. Here is our case. You guys see that okay? So we've got Timmy Johnson. Mr. Johnson is a 18-year-old, presents to your office complaining of recent onset of abdominal pain. So before we jump into getting the history and physical, which I know everybody always wants to do, let's talk about some roles first, and then we'll talk about some differential diagnoses. So who would like to keep track of the information? Who wants to keep track of our history and our physical exam? Any volunteers, or am I gonna? Amy, does that mean you're volunteering? Sure?
Yes.
Okay, so Amy will take track of our history, and then somebody want to be the scribe for keeping track of our learning issues, our differential diagnosis, and our well, learning issues and differential diagnosis, basically. Anybody want to do that for me, or am I going to pick somebody?
I can do that.
Okay, Jake's going to do that. Okay, great. So we got Amy and Jake. Okay, so you've seen our gentleman here. You've got the brief history. I know you want more stuff, but let's generate our differential diagnosis first, because that's going to be important in directing the rest of our questions in our physical exam. So what could be in our differential for Mr. Johnson?
Appendicitis.
Appendicitis, okay. Anything else?
GERD.
GERD, good. All right. What's GERD?
Gastroesophageal reflux disease.
Okay. What else could be in our differential?
Pancreatitis.
Pancreatitis. Okay. Anything else? What was that again? I'm sorry.
Gastroenteritis.
Gastroenteritis. Okay. Anything else?
Small bowel obstruction.
Ooh, small bowel obstruction. How would he get a small bowel obstruction at 18?
Maybe previous surgeries.
Okay. So, okay. Go ahead.
I was going to say, along with that, if he has irritable bowel disease, that could predispose him to it. And that could also go on our differential as well.
Okay, irritable bowel. Anything else?
Crohn's disease.
Crohn's. Shall we put all the inflammatory bowel diseases together? Should we cover Crohn's and ulcerative colitis at the same time? Okay, so put them both together. Anything else?
Constipation.
Oh, constipation. Let's think common things, because that's why they happen commonly. Anything else?
Could be something.
Nope. I heard gallbladder. What else?
Something kidney related. It could be actually lower in the abdomen, like a kidney stone.
Okay. Wow. Something other than the GI tract. There's other things in the in the abdomen other than the GI tract. Wow. Okay. Kidney stones.
In that same vein, testicular torsion.
Oh, okay. Good.
Peritonitis.
Peritonitis. Gosh, you guys are good. Anything else?
Mesenteric ischemia.
Mesenteric ischemia. All right.
A duodenal or ulcer.
Ulcer. Okay, I'll lump them all together as peptic ulcer disease. Okay. Anything else?
Aortic aneurysm.
Okay. Okay, well, that's a really good list. That gives us a lot of things, and I like seeing that you think outside the GI tract as well, because there are other things in our abdomen other than our GI tract. So let's do the history. Who would like to? Instead of having everybody shout out different questions at different time, let's have one person kind of lead the question asking. Maybe Whitney, I can get you to ask the questions, and then in the chat you guys can kind of prompt her with questions you'd like to have. I know you've gone through this a couple of times before, so we kind of know the standard format of what we want to ask, but this will make it a little bit simpler. So what I'm going to do is I'm going to stop sharing the screen, and then you just tell me what questions you want to ask, and I will give you the answers to those. So let's start with what you want to know. What's your first question?
When did this start?
When did this start? I was playing tennis when it first started about 5 hours ago. It was in my lower right side, and I thought it was a pulled muscle. I sat down trying to relax, but it didn't go away.
Okay. Can you use one finger to point to where it is?
Sure. Let me see about location. Patient points to the right lower quadrant.
Does anything make it better or worse?
The pain is worse if I try to straighten up, and it feels better when I sort of bend forward.
Does the pain go anywhere else, or is it mostly localized to just one area in your belly?
It's just right. It's right at the right side of my belly. As I said, at first I thought it was a pulled muscle, but now I'm not sure because it's kind of stayed there. I don't feel sore in my back, and I can walk all right.
Can you tell me what it feels like? Is it sharp, dull, burning, stabbing, something different?
Oh yeah, it's a burning pain in the lower right side of my belly.
Has there been any change at all since it started, or has it just been consistent since it came on?
Let's see, change over time. No, it's stayed right in the same location.
Okay. You ever had anything like this before?
I've never had anything like this before.
Okay. On a scale of 1 to 10, 0 or 1 being, absolutely no pain, totally normal, and 10 being the worst pain you've ever felt in your life, how much pain are you in right now?
Got to find the pain question. Hold on. Keep clicking on the wrong button. Oh, sorry. It's about a 5 out of 10.
Okay. And have you had any other symptoms along with this pain? Anything like nausea, vomiting, changes in your bowel movements like constipation or diarrhea?
I haven't had any constipation. Diarrhea, not really. What was the other one you wanted to know?
Any nausea?
I feel nauseated, but I haven't thrown up at all.
Okay, thanks. What do you think it might be?
That's a great question. I really have no idea, he says.
That's all right.
Remember, he's 18, so.
Have you been feeling well overall? Any recent illnesses? Have you had a fever?
No, I've been feeling great. As for a fever, oops. Really no fever.
Okay. We'd like to ask you a few questions about your medical history just to understand if there's anything there that might be contributing, if that's okay.
Sure.
What's the last thing that you ate?
I eat really healthy. I had a smoothie this morning before I went to go play tennis, but I really watch what I eat. I guess you could probably say that I'm kind of a health nut.
Okay. And any changes in your eating habits recently? You said you've been a health nut. Is this a new diet, or have you had this diet for some time?
No, I've done this for a long time.
Okay. Any new medications that you're taking?
The ENT surgeon started me on some Keflex, 500 milligrams twice a day for post-op infection prevention. He said I didn't have an infection, but he gave me this medicine. Started it yesterday. And he also gave me some Tylenol with codeine for the pain.
Okay, thanks for sharing that. So I'd like to know a bit more about the ENT surgery, if you're willing to share. What did you have done?
I had a nasal septal repair yesterday. I had a deviated septum. Other than that, I'm really healthy.
And you said that the provider that you saw gave you Keflex. So did you take the first dose yesterday, or was that today?
You've taken 2 doses so far. I took a dose yesterday and I took the dose this morning.
Okay. Now, have you been able to eat or drink anything since this pain started?
I haven't really tried.
Okay. And beyond the nasal surgery, do you have any other chronic conditions, anything that you take a medication for on a daily basis?
No, I'm otherwise really healthy.
Okay. And any other hospitalizations or surgeries in your past?
Nope.
Okay. And just to triple confirm, you said that the surgery was yesterday.
That's correct.
Okay. And was it outpatient or did you have to stay the night in the hospital?
No, outpatient.
Okay. Very good. And 5 out of 10 pain, you said.
Yes.
Got it. Okay. All right.
I have a question. What's the significance? You guys seem to be interested in this recent starting of Keflex and the surgery yesterday. What's the significance of that? Why has that all of a sudden become such a big deal?
Isn't a side effect of Keflex nausea and vomiting, and he has a GI complaint.
Okay. You guys agree with that? Is that one of the side effects of the antibiotics? Could that be causing his abdominal pain, the medication?
Well, he was taking codeine too, and that's an opioid, and there's some constipation with that. So.
Okay. Okay. So does that make the things like the constipation and the bowel obstruction, does that move them up on our list now because we know of this, or is it really still not enough information?
I would say still not enough information yet.
I
Okay.
don't
So
think bowel obstruction is up.
let's talk about small bowel obstruction for a second. You a minute ago, when we put that on our list, you said that it was usually due to prior surgeries. I would imagine you mean abdominal surgeries, correct? Not his septal deviation surgery. So since he's had no prior surgeries, does that kind of eliminate the chance that he has a small bowel obstruction?
Not eliminated, but it's lower on the list.
Much lower on the list? Okay. But not enough for us to take it off our list yet. Okay. Okay. Let's go through some of these other things here real quick in the differential. What about appendicitis? Is that still up on our list? Okay. What about appendicitis makes this up on your list? Why is this still high on your list?
Location of the pain and the onset.
Okay. So location, location, location. Okay. So that would be still high on our list. What about GERD?
Less likely given location of the pain.
Okay. But doesn't GERD have kind of a burning pain? And he describes it as a burning pain.
Yeah. The acuity of it probably makes GERD lower on the list since GERD's more of a chronic condition.
Okay.
It seems like an acute process.
Okay. Enough for us to cross it off or just to put it lower on our list?
I mean, we can
Lower on
add,
the list.
yeah, I mean, he might have underlying GERD, but I mean, unless we really get into his diet history and he's having reflux symptoms every time after he eats a certain food, it's probably safe to say this 18-year-old doesn't have it at this point.
Okay. What about pancreatitis?
I wouldn't cross it off, but it's more characteristically in the left upper quadrant.
Okay. What
Yeah,
causes
it's
pancreatitis?
alcohol intake as well.
So we'd want to know his alcohol intake?
Mm-hmm.
Yes.
I know that was probably one of the questions you're going to ask, so I'm going to give it to you right now. He denies never any alcohol intake. What's the other
Also
cause?
due to obstruction from gallstone.
Mhm.
Okay.
Or
Okay.
high fat diet.
Okay. Okay. So it's down on our list. We're not crossing it off yet. Or are we crossing it off because of the location?
We're not crossing anything off.
Okay. How do we approach, this abdominal pain? You guys seem to be talking about location and where things are and why he has pain in certain areas. And his is all right lower quadrant, I think he said, the right side. And you keep saying, oh, well, pancreatitis is here and GERD is here, so it's less likely. What's our approach then to working up somebody with abdominal pain? Is that like really related then to where they're having the pain? What else do we want to, is that like a key thing?
Yes.
So if I told you that he had right upper quadrant pain, what would be in your differential for right upper quadrant pain?
Gallstone,
Cystitis.
hepatitis.
Hepatitis. Okay. So it's really based on the organs that are in that location, I guess it sounds like. Maybe we should make a learning issue of maybe a diagram or something of where, based on the quadrants of the, because how many different quadrants are there in the abdomen?
4.
Okay, maybe we should make, somebody could do a learning issue. I'll write it down as a learning issue. We can keep track of the quadrants of the abdomen and what our differential would be based on their based on where the location of their pain is. Okay. Okay. What about you had irritable bowel and Crohn's and ulcerative colitis. What about those as part of our differentials? Is that still on our list, or are we taking that off? Still on our list?
A
It
list
might
of
be a
family
little.
history pertaining that, because that can be telling. And then he denied, I believe, nausea and, well, not nausea, but vomiting and diarrhea and other bowel changes. So maybe less likely, but we could dig more on that.
Okay. Constipation, I heard somebody say earlier that's still on our list because of the opioids that he's taking. But antibiotics cause diarrhea and opioids cause constipation. So wouldn't they match each other out and just leave normal bowel movements? Or doesn't it work that way?
No.
No, it doesn't work that way. Okay, so we'll leave that on our list. You guys still said gallbladder is a possibility because of the pancreatitis as a possible etiology. What about kidney stones?
Usually that would radiate to the groin, and he said it's basically in one area, so maybe lower on our list.
Okay. How would we... Go ahead. Sorry, Amy. Go ahead.
I was just saying he denies back pain as well.
Okay. So how would we eliminate... What could we do to evaluate him or eliminate kidney stones from our list?
You could do a CVA tenderness on physical exam, and of course, you could do some imaging, like a KUB or something, to see if he's got any stones.
You can do a quick urinalysis as well to check for blood in the urine.
What's a KUB?
Kidney urine. Yeah.
Okay.
X-ray.
Is that an abdominal X-ray?
Yes.
Okay. 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 Testicular torsion was on our list. Still a possibility?
Definitely possible given the onset during exercise, but the pain is not radiating anywhere. So.
Okay. And that's not one we'd want to miss, right?
No.
Okay. And then peritonitis, I guess, would still be on the list since we had all the other pancreatitis and stuff. What about gastroenteritis? What causes gastroenteritis?
It could be viral, most often,
Okay.
sometimes bacterial.
Yeah, food poisoning.
So would we want to know, what would we want to know to help us either think more about gastroenteritis or eliminate it from our list?
Sit contacts.
Okay. Remember, through this process, we're trying to get you guys to start to think, what do I need to add? That's why I kind of stopped this halfway through Whitney taking the history, because I wanted to see, let's direct ourselves back to what questions we really need to ask related to our differential. Okay. And then peptic ulcer disease was on our list. Do we keep that on there? Is there anything we need to ask and follow up, or?
If he had a history of cigarette smoking or prolonged NSAID use, he could be more pre-exposed to it.
Okay, so we'll want to ask about smoking. He says he's not taking any other meds other than the Keflex and the Tylenol with, but we could ask about over-the-counter medications as well. Okay, and then what about AAA, abdominal aortic aneurysm? Seems kind of young for that.
Biggest factor there would be checking for a family history.
Okay, so we got to get the family history. Okay, let's go back to asking some more questions now that we've figured out what other things we may need to ask. So Whitney, take it away again. What else do we need to ask now?
Sure. So can we ask social history? So we mentioned smoking history.
Sure. Smoking. No, never to tobacco. What other one?
Any vaping or drug use?
No, let me ask about drug use. Substance abuse? No, never. I wouldn't touch that stuff.
Okay. And I'd like to ask sexual history. So is he sexually active? Has he ever been sexually active?
Okay. I fooled around with a couple of girls, but I used protection like they told us in school. Why did you want to know that? There wasn't, I don't know of anything on our list. It's a good question, but why did you want to know that? There was nothing on our list that I could at least make that a relationship to. Well, why was that important?
I was thinking, I mean, again, we might get into the physical exam and find that he has some testicular pain. You could certainly have like an epididymitis that's causing referred pain to the abdomen. You could have an STI that's ascended. So, I mean, less likely, but I also think it's just a good idea to always take a sexual history.
Okay.
You may pick up something incidental that's important.
Okay, well, I'm going to add, let's add epididymitis and then STIs to our list as well, just to complete the picture. Okay, good. Anything else history-wise?
How about any recent travel?
One of my favorite questions in the whole world. Let me see here. Gosh, where did it go? Oh, there it is. I went to Bermuda with my family 6 years ago. Probably not related to anything right now, right? 6 years ago. Unless some weird smoldering parasite.
And how about anyone else that you know that's sick?
Okay, let's see. Nobody in the family no family or friends have the same problems that I do.
Thank you. Can we inquire about his insurance status just before we start getting into, thinking about what diagnostic tests to order and things like that, financial situation?
Sure. Mom and Dad complain that we never have enough money to do everything, but we live pretty good. I know we have good health insurance. It even covers the dentist.
Okay, thanks for sharing that.
Anything else? You mentioned physical exam that we had to do coming up here. We'll do in the next session. Somebody mentioned about CVA tenderness. What is that?
It's tenderness at the costovertebral angle.
Where's that?
Just kind of below the rib cage on the back on both sides.
Okay. And then somebody mentioned having to do an abdominal exam. What are some of the components? What are we going to have to do as part of that abdominal exam?
The first step would be to inspect. So looking for any lesions, prior surgery marks, or anything like that.
Okay. And then what?
Then we listen before we disturb anything because we want to see the bowel sounds if they're hyperactive or hypoactive.
And then?
And then
I know you're always going to save the part that hurts for last. So you kind of, we would save the right lower quadrant for the last part, but then you would palpate. So first gently and then deeply, but definitely want to make sure that there's not like a rigid abdomen. That would move something like peritonitis down on our list.
Okay.
And before palpating, we would percuss too.
Okay.
Looking. Yeah.
How would you know if somebody had a rigid abdomen?
they're stopping you from pushing on it.
So what would cause somebody to have a rigid abdomen?
Peritonitis.
So
Abdominal
what
emergencies.
I mean, I'm trying to, so what's peritonitis? What's the underlying mechanism for peritonitis?
So there's inflammation around the membrane that encompasses the visceral contents of the abdomen. And so if you had like a perforation and it caused an infection, it would affect the peritoneum, causing peritonitis.
I still don't, so I've got an infection that's inflamed. I still don't understand how that's going to cause pain.
That might be a great LI.
Okay, let's talk about, we'll make it pain with peritonitis. Okay. And then somebody mentioned we need to get a UA, a urine analysis, because of the kidney stone, I think it was. So what in the urine analysis would be helpful for us for the kid? Because the only thing we have on here that's related to kidneys really is kidney stones. So how is that going to help us rule in or out kidney stones?
Blood on a urinalysis can be highly indicative of
Okay.
a kidney stone. Urinalysis can also help us rule in or rule out other urinary pathologies like a urinary tract infection.
Would it help us with the epididymitis or the sexually transmitted infections? So if he has chlamydia or gonorrhea, that can't be found in the urine in men?
That's sterile pyuria usually, so it doesn't always come up. You'd have to send it off.
Okay.
Checking for gonorrhea, chlamydia is an additional test you order, like a nucleic acid amplification. It's not something you get on a UA in clinic.
So do we need to order those tests as well? And what did you say, nucleic acid what?
Nucleic acid amplification test, NAAT.
How does that work?
That would be or an LA on the lab process.
Okay, we'll make a LI on the how that test works, what an NAAT, what it is. Okay. Okay. Any other questions we need to ask, Mr. Johnson? Whitney, you're on mute. Sorry.
Thank you. There are a few more questions.
Sure.
Any family history of anything like IBD?
Family history. My grandparents and parents are alive and well. I have 2 older brothers who are healthy. There's no family history of anything like hypertension, diabetes, high cholesterol, heart disease, or cancer.
Right. And no kidney disease, I would assume. Not
that I know of, no.
Okay. I'd like to move to the review of systems.
What's review of systems?
So just going through the body systems in a methodical order. So making sure that we are asking pertinent questions to help rule in or rule out various diagnoses. Okay.
Let's do that then. So what's first?
So just generally speaking, we already asked him about fever, but constitutionally, is he feeling well overall, minus this abdominal pain? Any?
Just the pain in the right side. Other than that, I feel fine.
Okay. And no chills, unintended weight loss, that type of thing?
No chills. And no weight change.
Okay. So we could hypothetically go through all the systems, but in a focused ROS, there are some systems I don't think are necessarily important to ask about. So we could inquire about his, vision, that kind of thing. But I would like to ask, just because he had recent nasal surgery, this probably is not relevant to the case, but surgically, is he doing okay after the surgery? Any, bleeding, any, pain in his face that seems out of proportion, anything like that we need to worry about?
I was always congested. That's why I had to have surgery on my nose.
Okay.
There's no bleeding noted now. My nose is a little sore and it's a little, I think it maybe looks a little red, but it's not. And there's a little tenderness after the surgery. And I haven't had to take, it actually says I haven't had to take much of I've only taken the Tylenol with codeine once.
Good. And no foul odor from the surgical area?
No.
Okay. All right. So any shortness of breath, any trouble breathing, exercise intolerance?
No shortness of breath, no dyspnea, no chest pain related to breathing, no respiratory complaints, no history of asthma, bronchitis, or wheezing.
Okay. And any heart palpitations, chest pain, feel like your heart is beating funny or skipping a beat?
No heart irregularities, no palpitations, no chest pain. I think that was it. Yeah.
Okay. And how about any noticing like a dark or tarry kind of stool? Any different color, different texture to your stool?
I'm usually go every day, but today I haven't had any urge.
Okay.
Not when you ask me about constipation, it doesn't really say constipated, just the issue today. Hasn't been vomiting, and then you wanted to know about changing the color of his stool. No rectal bleeding, and the color of the stool. I don't usually look, but I think it's brown. I never saw any blood on the paper or in the bowl.
Okay. And any like foul smelling stools that are floating on the top of the toilet, anything like that that's unusual over the last few weeks?
No.
Good. And are you able to pass gas?
Yes.
Good. Do you feel like your belly is bloated at all? Or does it feel normal?
No, it feels like it's burning and kind of cramps at the same time.
But no bloating?
No, this is just some of the worst pain I've ever had. He doesn't mention anything about increase in abdominal size.
And have you been able to drink any water? I know you mentioned you haven't had much of an appetite to eat today, but are you able to drink water?
I haven't tried since the pain started. I had some water while we were playing tennis, but since the pain started, I have not tried to drink any water.
Okay. And how about any, like, feel like you need to go to the bathroom a lot, any burning or pain when you urinate?
Not going any more than normal, and I haven't noticed any change in how often I go or how frequent I go, and
Okay.
It doesn't hurt for me to go.
Okay. And have you noticed any different color to your urine? Anything that looks like pink or red?
No.
And do you know, did they have to insert a urinary catheter when you had your surgery yesterday, or?
No, I was only in surgery for a couple of hours, so
Okay.
I was in and out of there and they woke me up pretty fast.
Good. Good. How about any pain in your testicles?
No.
Okay, great. Any dizziness, fainting, or headaches that you've noticed?
Dizziness. I felt a little woozy yesterday coming out of surgery, but nothing since. And what was the other one you wanted to know? Dizziness and
Any fainting or headaches?
fainting, no. Headaches. Once in a while, and I'll take a Tylenol, and that takes care of it, but nothing recently.
Okay, perfect. Thank you. And you haven't noticed any like unsteadiness or trouble with balance at all?
They said I was a little out of sorts after surgery, walking to the car. I know my parents said that I was a little unsteady, but I was fine playing tennis today, so
Okay.
I still was beating them.
On that topic, did the ENT say it was okay for you to go back to playing tennis so shortly after your procedure?
He just said I shouldn't play real hard, and
okay.
Don't tell him, but I've been playing kind of hard.
I know it's hard to hold back. So
yeah.
All right. And last couple of things. Any pain at all as you've been walking or riding in the car? You know, in your belly, like with movements such as moving around?
It's really hard to say. I mean, it was pretty smooth coming over here, but I'm just uncomfortable. It's just, I mean, it's not getting any better. I mean, this isn't like cramps or something I've had before with prior, episodes of diarrhea or whatever. This is not getting any better.
Yeah, understand. Okay. That's good.
Okay.
Should
Any
we,
other? Sure, go ahead.
I was going to say, before we move on to physical exam, should we redefine like our top 3 differentials so we can focus our physical exam on that?
Sure. What I'd like to do first is just kind of, we've kind of gone back and forth between the history. So I'm wondering if, I can't remember, I think it was Amy, you were taking notes of what was going on. I'm wondering if you could really give us just a brief 30-minute review of what we know about Mr. Johnson so far, so that as we go back to that differential diagnosis, we're all kind of on the same page again.
Okay. So we have an 18-year-old male with recent onset of abdominal pain. It started acutely while he was playing tennis. It started in his left lower quadrant. So he sat down. It's now in his right lower quadrant. Straightening up helps him feel better. He denies back pain. It's non-radiating, but it is a constant pain that he's never had before. It's about a 5 out of 10, a burning sensation. He has nausea, burning, and cramping, but he denies constipation, diarrhea, vomiting, fever, chills, and weight loss. He eats pretty healthy. He just had surgery yesterday for a nasal septal repair. And he is on 500 milligrams of Keflex 5 times a day with Tylenol and codeine.
Okay. Anything else anybody wants to add? Okay, that was good. Okay, so let's run through our differential here real quick. Is appendicitis still on our list? And what do we need to do physical exam wise, if anything, to eliminate it or move it up on our list? So I'm taking all the nods or yes, we're keeping that on our list. And I guess the abdominal exam will be the one that'll help us with. Is there anything that specifically we're looking for related to appendicitis?
Like rebound tenderness.
Rebound tenderness. How would we test for that? Well, how do you do that?
You push down deep, and then when you let go, if there's pain when you let go, that's the sign.
Now,
Or is rebound tenderness, actually, is that more specific to peritonitis, not appendicitis?
I don't know.
I think I may be incorrect on that.
I was just gonna ask if like anybody has done rebound tenderness on anybody who's like acutely peritonitic before. Like yeah, I think yeah. I've heard more people, or I've heard from people that it's better to just like bump the bed or something, or like just percuss over it. And if they're acutely peritonic, you're gonna know. Versus
it's not nice. Does not feel nice.
jamming your hand into somebody's like a inflamed appendix.
Okay. So with that rebound tenderness, if we did that, is that specific for appendicitis or is that more specific for peritonitis, or doesn't it really matter?
Well, I know there's the Rosbing sign. So that's when you do it in the left lower quadrant, and then you do the rebound tenderness. And then if they feel it in the right lower quadrant, that's where the appendix is. So I think that would be something specific for, I always forget specificity versus sensitivity, but I think that would be specific because that's ruling it in towards appendicitis. Yeah.
Okay. Okay. So we're going to do those parts of the physical exam. What about for GERD?
Could be gastric tenderness. Might be more indicative of GERD.
So part of our abdominal exam again. Okay. And pancreatitis, same thing. Is that still just part of the abdominal exam, or are there other things we need to do for pancreatitis?
Amylase and a lipase are probably your best option to rule in pancreatitis.
So are there any labs for appendicitis or GERD?
Well, for appendicitis, the white blood cell count is really helpful.
Okay.
For GERD, you do an H. pylori test just to make sure that's not like a bacteria that's in their gut, because you definitely have to treat that with an antibiotic on top of the PPI. So you would just check if that bacteria is producing any urea.
Okay. So if his physical exam doesn't indicate anything in the gastric area, we wouldn't necessarily need to then do an H. pylori test.
Yeah, you're not just gonna do
okay.
I want to tailor it to what's specific to
okay. What about the gastroenteritis? You guys talked about viral gastroenteritis. Is there any, I guess the abdominal exam will be important there. Is there any labs that would help us with that? I mean, he doesn't have any diarrhea, doesn't have any constipation. Or are we crossing this off our list?
I think it might be unlikely that it is without diarrhea.
Okay. Ooh, we're crossing something off. Yay!
Yeah, he's not systemically sick either.
Yeah, it's okay to cross things off the list. Okay. That's part of thinking through a differential diagnosis. Small bowel obstruction, I think we're still going to have to do is. Would small bowel obstruction also show this rebound tenderness?
I think we can rule it out. He's passing gas and he's had a bowel movement.
Okay. What about irritable bowel syndrome?
More of a chronic diagnosis. It would never be made on a single instance of illness like this. So I would say it can be crossed off.
So unless this is his very first episode ever, it would, okay.
You have a lot of things to do before you diagnose it as IBS.
Okay. What about Crohn's and ulcerative colitis?
This could technically be a first episode of those.
Okay. But it certainly wouldn't have been chronic disease yet because this is his first episode. So this would really be down arrow then, low on our list. Okay. Constipation is still on our list. Okay. What about gallbladder disease?
He does not in the slightest fit the normal demographic for someone who has cholecystitis.
So please tell me, who's the normal demographic for somebody with gallbladder disease?
It is an overweight female in her 40s who has potentially recently had a child. So I know Native Americans tend to also be predisposed toward cholelithiasis, so a cholesterol gallstone, but he's none of those, obviously. So.
Okay, so he doesn't fit the picture on any one, not even one. So are we crossing it off then? Is that I mean, how unusual would it be for an 18-year-old to have gallbladder disease who eats healthy? That would be pretty unusual. So we crossing it off? Good. That's the way you think through these things. That's the way you use what you know about disease epidemiology and the way they present to help you. Could you be wrong at times? Yeah, but that would be the most unusual thing. Plus, aren't we doing a physical exam on his abdomen? So as we're going around and doing the abdominal exam, if something popped up in that, where would his abnormality be? What quadrant for gallbladder disease?
Right
Upper right.
Yeah, so if all of a sudden something pops up in his right upper quadrant that's abnormal, we go, oh, maybe we need to add this back in. But I like that thinking. Kidney stones we were leaving on the list. You guys wanted to get a UA. Testicular torsion.
He denied testicular pain, and that it would be very painful with torsion. So I think it's unlikely.
Cross that one off. We're leaving peritonitis on because we've been talking about all the rebound. Mesenteric ischemia.
I would say less likely. I mean, that's usually a chronic disease, older patient who has atherosclerotic changes. He also doesn't have poop, pain out of proportion to. Okay.
So you're saying the underlying mechanism for ischemic mesenteric ischemia is vessel sclerosis. So how would that lead to, I guess, so I understand ischemia in the heart, you block off a coronary artery and that decreases blood flow to the parts of the heart and they have chest pain. Is that the same thing that's going on here then with mesenteric ischemia? So what vessels are being affected?
The superior, inferior mesenteric arteries.
So what does the superior mesenteric feed? What part of the abdomen or what part of the internal organs does it feed?
Midgut.
And then what about the inferior mesenteric?
The hindgut. What's
the separation between midgut and hindgut? You didn't think you were getting off that easy, were you, Taylor?
It's the distal, the distal third of the transverse colon.
Okay.
And then there's an anastomosis in the mesentery.
From the splenic flexure onward.
Okay. Where's the splenic flexure?
At the intersection of the, transverse and descending colon. Right next to the spleen.
Okay. I'll tell you what, let's, just for my own clarification, maybe we can have somebody make that a learning issue just to come back with a diagram that kind of shows, because I think I understand where you're talking about, but I'm having a hard time visualizing it in my brain. So and then peptic ulcer disease, is that still on our list?
I don't think he had any symptoms of dyspepsia, so probably not. No bloating, nothing that would suggest peptic ulcer
So we
disease.
cross it off.
I'm okay with crossing it off.
Okay. What about AAA? Cross it off?
Yeah, he doesn't have tearing back pain, or hopefully not a pulsating. We can listen for bruise.
A little young for AAA.
Yeah.
Okay. And then what about the epididymitis and sexually transmitted infections? Are we still, at this stage, do you still think we need to get the cultures and stuff, or is this still on our list, or based on our history, can we, or do we need to examine them yet?
In a young sexually active male, if he hasn't had STI screening in the past, there's nothing wrong with getting it now, even if that's not the cause.
Yeah, we'll still do our GU exam too.
Okay, we'll leave it on the list. Okay, so we've got the learning issues.
Can I suggest another differential? Did anyone say diverticulitis? I know he's young, but maybe he has like Meckel's diverticulum or something.
Sure, I had it on there. So how would diverticulitis present?
Abdominal pain.
Okay, looks like we're making diverticulitis a learning issue. Okay, so what we'll do is we'll divide up the learning issues, and the next time we get together, we'll go through the learning issues first. Then we'll do our physical exam, and we'll see if there's anything else that we need to go off and learn. And then when we come back, we'll see where we are with our differential, and then we'll finish up on the third day with how we're going to treat our young man. So let's divide those things up. I'm not going to divide them up, by the way, you guys. Okay. Well, actually, we can divide them up here real quick. Who wants to do the quadrants, the differential diagnosis, and create that diagram for the differential diagnosis? Amy, you'll do that one.
Nope.
Who wants to do what causes the pain with peritonitis? What's the underlying mechanism? I think who was discussing that one? Okay, we're going to give that one to you. That's what you get for bringing it up. Okay. And then I forget who it was. Brianna, was it you who talked about the NAAT testing?
Yeah.
Okay, you got that one. And then who wants to talk about go and look up rebound tenderness? The question was really about the significance. And I think Tyler, it was you said, you don't really want to be pounding on their abdomen, so we can hit what I'm interested in is hitting their bed or wiggling their foot, is that really going to be as good a test as pounding on their belly? So Tyler, I'm going to give that one to you, since you seem to be hooked on wanting to just touch their leg or wiggle their arm. Not saying I disagree with you. It's what I used to use too. And then we had a thing about the blood flow in the abdomen. Who wants to take that one?
I can take it.
Whitney, okay. And then our last one was kind of a review of what the causes and some of the signs and symptoms of diverticulitis. Who wants to do that one?
I can do that.
Who was that? Aaron? Okay. All right. Okay, so we will see you guys the next session, and we'll start off by going, we'll do a quick presentation of the case. Maybe we can have Amy do that again, and then we'll go through the learning issues, and we'll do the history, and we'll go from there. So we'll see you guys next time. So normally there'd be a break there. You guys would go off and do all those things. We would come back. So here we come back. So welcome back, everybody. We're going to finish up the next step with Mr. Johnson today. So to get us all back on the same page, Amy, can you give us another brief update on Mr. Johnson?
Yes, so we've been working on crossing out differential diagnoses. We have this 18-year-old with recent onset abdominal pain that won't go away. Started in his left lower quadrant. It's now in his right lower quadrant. It hurts when he straightens up, or it's better when he straightens up and worse when he bends forward. He denies any back pain, and it is non-radiating pain as well. It is constant. He's never had this before. It's a 5 out of 10 pain that he describes as burning. He admits to nausea, burning, and cramping. He denies constipation, diarrhea, vomiting, fever, chills, and weight loss. He eats a healthy diet, and he just had surgery yesterday for a nasal septal repair because he was always congested. Now he's currently taking Keflex 500 milligrams 5 times a day and Tylenol with codeine. He denies tobacco use, alcohol use. He does have a sexual past history, but he always has used protection. And no recent travel, no other sick contacts.
Okay. Anything else we want to add? Okay, let's go through our differential diagnoses here. Well, before we start with the differential diagnosis, let's talk about one of the learning issues was the different quadrants and locations. And Amy, I know we gave that one to you. What I'm going to do is I'm going to share the document that you prepared. I'm going to show it to everyone here. Hold on. And then we can kind of go through that. There it should be. Can you see that?
Yes.
Okay, so take me through this a little bit. We don't have to go through each item that's on there, but just tell me a little bit about why, and then let's really focus on the right lower quadrant. Let's kind of compare the list that you found from this wonderful diagram, by the way, compared to the list that we had. So.
All right, so this is a diagram of our 4 quadrants of our abdominal. And we can use our anatomy to help us rule in or rule out specific diagnoses when we're looking at our abdominal cavity. So we have a right upper quadrant, and here we have listed several things that are in this right upper quadrant and things that can be causative agents. And then we also have listed in all the other quadrants as well. So we have appendicitis down in the right lower quadrant, and that's where his pain is. That is definitely on our differential at this time. And then we also have GERD still on there. I think, I can't remember if we crossed that one off or not.
We left GERD on the list.
Okay, so that's more epigastric. But yeah, this diagram is just helpful so we can go through our differential and kind of figure out and go through the right lower quadrant categories to decide if we can cross out anything else or add anything that we haven't thought of.
Okay. What about the things that are in that right lower quadrant? How did we do pretty good compared to our list of what we had on our diagram? I mean, what's on the diagram that you put together? How does that compare to the differential we came up with? Did we do good?
I think we did pretty good. I think we can add a couple things like the hernia. And then we can cross off things on here because we have a male.
Okay, that's always makes it easy, yeah.
And yeah, I think we did pretty good.
Okay, okay. Let me stop sharing that for a second. Or did I stop sharing it already?
No, it's still up.
Oh, there it is. Sorry, there it is. There it's going. Okay, so let's go through our differential then. What about the appendicitis? What about, is that still on our list? Is it still high on our list, low on our list, medium on our list? Do you think this is likely? Does he fit the right group? So you would say that's a big up arrow one, I guess is what I'm hearing from you guys. Okay. Is there anything else? Somebody said something about we still need to get the physical exam. So will that, we talked about running to do the Rossing sign and stuff, so we still have to do that. What about the GERD? Is that still something we need to think about?
Not really. I mean, he's a young kid and he's healthy, and you know, usually you think that in older individuals with a poor diet.
Let's take GERD off then. Okay. What about pancreatitis? Guess we still need the abdominal exam, the amylase and lipase we wanted. What about the Crohn's? Oh, is there anything that changes? You guys have the list in front of you. Anything that changes? Do we take off or leave on Crohn's, ulcerative colitis, constipation, the kidney stones, or do we still need to do the physical exam and some labs here to really separate those out?
I would be shocked if it was UC and he was not having bloody stools.
Okay.
So I think, I mean,
Okay.
you could leave like a Crohn's on there because it typically isn't bloody, but for UC, it would be a very weird presentation.
Yeah.
What about that? Oh no, go ahead. Sorry.
I was gonna say, and if we just consider the acuity of it, I think inflammatory bowel, unless this is a first episode, which it very well could be, but I mean,
okay.
I mean, if we're going off this one instance, I'd say take inflammatory bowel off the list, and we can still do the UA for nephrolithiasis.
Okay. What about diverticulitis?
Technically still possible. I mean, generally you think left lower quadrant, but there are some rare cases where that pain is right lower quadrant.
Okay. Anything else we need to know? Go ahead. Sorry.
I feel like it'd be interesting for diverticulitis in an 18-year-old and to not be localized to like the left lower quadrant. I've heard it called like not crossing it off. I think it'd be weird, and really the only way to confirm it is to go and scope it. So I mean, I'm not sure we're going to scope an 18-year-old at this point. So
okay. What causes diverticulitis?
Well, they're like these outpouchings called the diverticula, and when they get obstructed from like stool and constipation, they can get inflamed and infected. But if he's young, we can think Meckel's diverticulum, just a congenital.
Okay. Okay. Somebody made the comment about a CT scan. Would we really want one of those? That's a good thought. Do we need one of those at this time?
I think he's really young. It might not be our first line imaging because we don't want to expose him to too much radiation. I think an X-ray might be helpful.
Okay. And then we had mesenteric ischemia, and it seems like we almost wanted to cross it off the last time, but we weren't quite sure of the blood flow. And I think Whitney had that one. Let me bring up the document that Whitney prepared for this. I think this might help us answer our question. Can you guys see that?
Yep.
Yes, I can. Okay. So I think it was Tyler or Whitney, I can't remember, we were trying to divide up where the foregut, hindgut, and you were talking about third of transverse colon and splenic flexure. So I see that the top big vessel there is the superior mesenteric. And when I look at the way this blends together, it looks like it covers the entire small and large intestine. So if you were to block off the superior mesenteric, you could actually destroy your entire gut.
You would die.
But so why then you have the inferior mesenteric, which seems to do some blood supply to the rest of the gut as well? It seems like there's a lot of crossing over and collateral circulation there. Am I missing something? You guys were pretty adamant about dividing the gut at a certain level.
So you are correct that there are a lot of anastomosis where the blood vessels cross over and supply maybe, the same section of bowel is supplied by two separate portions of whether it's the SMA or the IMA. But, ultimately these are very, very large blood vessels that carry a lot of supply. And so if one of these arteries is occluded, it can become very problematic because you mentioned the SMA supplies almost the entirety of the small intestine and then a very good portion of the large intestine as well. And if those arteries are somehow blocked, the bowel can basically just dies because it loses its blood supply. So that is a true abdominal emergency. As far as the IMA is concerned, it's not great. You can live without a portion of your large intestine much more readily than you can live without the things that the SMA supplies. And you're mentioning the splenic flexure. So that is an area where that particular portion of the colon on that kind of left upper quadrant over there. Yep, exactly. Which is right adjacent to where the spleen sits, superiorly. That is supplied by both the SMA and the IMA. It's a good anatomical landmark when thinking about blood supply. But to the point of this patient, the portion of his bowel that would be involved would be pretty much, only supplied by the SMA. So he would be in a really bad spot if he had an SMA infarct.
So if I had the SMA infarcted and I was stopping blood flow, wouldn't I have diffuse abdominal pain practically everywhere?
Very most likely.
And he doesn't have that. And if he were to have the inferior mesenteric obstructed, that would be mostly, I got to get my left and right
lower quadrant.
Left lower quadrant, and he's got white lower quadrant. So can we, for a number of reasons, I think Taylor brought up last time, that he's not the right age. He doesn't have a history of atherosclerotic disease. So Tyler said, based on that, we kind of wanted to cross it off the other day. Now that we know the physical exam or the anatomy of the blood flow, we can pretty much cross this thing off then.
I'd be very surprised if this was it. And especially because he presumably would have had an abdominal exam yesterday before he went into surgery. He's had very recent contact with the healthcare field. So I would be shocked if this was it.
I'd be shocked if an ENT touched the tummy.
Yeah, but
I
maybe
agree, Tyler.
Maybe the ENT had a PA in his practice who decided to do a complete physical exam. So we'll hope. So, okay, so let's go do the physical exam then for today. So since Whitney, we had you do the history, let's just continue with having you do the physical exam. So.
Sure. Well, generally.
Let me give you the vital signs first. Okay. I'm gonna cut and paste those and put them into the chat for you so you can see them. Then we can talk about them for a second. So there's his vital signs. Anything you see that's abnormal, I guess if it's not abnormal, it would be normal. So anything there abnormal? Okay, so he doesn't have an elevated heart rate. His blood pressure looks fine. His temperature's fine. What's this slight sinus arrhythmia? I see that a lot. Is that a normal thing?
Normal for an 18-year-old, healthy 18-year-old, yes.
Okay. So we had on our list CVA tenderness, abdominal exam was the two big areas that we wanted to do. So how do you do the CVA tenderness?
So you take your hand and you put it on the patient's flank on their back, and then you use your other hand to sort of pound like this. You can do it directly on their back, but I like this. I think it's a little less painful, and that should elicit pain in that specific area for them if it's positive. I don't find that it's terribly sensitive. I've had patients who I've done this on and they turn out to actually have a kidney stone, and no, they don't have any tenderness, but that's how you would do it.
Okay. So it says when you do that, percussion of the costovertebral angle did not elicit any discomfort. So does that mean he's negative for CVA tenderness?
Yes.
Okay. Does that then eliminate kidney stones, or is that not enough yet? We still need to do the UA.
Do the UA.
Still need to do the UA. Okay. So what else on physical exam?
It's probably a good idea just to look at the kid. Does he look toxic? Does he look well appearing? Generally.
Okay.
Isn't it with kidney stones? Isn't the old adage that when you walk in the room, they can't sit still? They're moving from chair to chair, and they just can't sit still.
It's not an old adage; it's an adage. It's old, new, and intermediate. Trust me, I've had 5 of them. You cannot sit still. So he looks in minimal distress due to right lower quadrant abdominal pain. It says here does not have a toxic appearance. I don't know what that means. What's a toxic appearance?
They're like pale. They might be sweating. They look real sick.
Okay.
You know it when you see it.
You know it when you see it. Okay. Okay. So what's next?
So we already did the vital signs, which would be the next appropriate thing. Again, I think a focused physical is perfectly appropriate for this patient since he's obviously not having any other issues. Again, he just had surgery, so I would take a fleeting glance at the nose just to make sure that there's no issue there. No need to remove any dressings or anything, but is his face looking okay? No erythema?
There is evidence of recent surgery with minimal swelling, and no further examination is performed.
Perfect. So you could, it's always a good idea to auscultate, and you can percuss the lungs and over the heart if you like, but we could certainly auscultate as over our lung fields in 8 different spots, and then also listen to the heart.
Oops, hold on here a second. When auscultating the lungs, oh, come on. Lungs are clear. No wheezes, rales, or rhonchi are noted throughout the lung fields.
Front and back?
Back is the same thing.
Thanks. So I would listen to the heart sounds over all of the valves.
Okay. Regular rate and rhythm, no murmurs are noted. S1 and S2 are normal. PMI is noted, or I'm sorry, this was just auscultation. Nothing abnormal. S1 and S2 are normal, no murmurs are noted. Heart rate is regular rate and rhythm.
I would typically like to leave the problem child for the last. So I like to go in order, but I would not do an abdominal exam right now, just because that's where we think that the pain might be. So I would like to do that last. Okay. So potentially check the pulses, femoral pulses specifically.
Okay. Pulses are 2+. And that's all it says. No abnormalities noted.
Okay. Because we had something GU on the differential, it would be good to go ahead and do a testicular exam. Just make sure that he doesn't have any pain. Feel for hernias as well.
Sure. The penis is without discharge. The skin is darker color than body skin. Circumcised, the glands is pink, dry, without lesions. Urethral meatus is open. Palpating. Scrotum is relaxed, but the cremasteric response is active. No excoriations or rash. The testes are in the scrotum, both being about 4 centimeters long, ovoid in shape, and mildly tender. The epididymis on each side is soft and non-tender. Spermatic cord is identified on each side. No cystic or nodular masses are noted on either side. There's no hernias or varicoceles in the scrotum. It says that it's minimal, mild, the testicles are mildly tender. Is that normal or is that abnormal? That's normal? Okay. Okay, next.
And I was just going to say on that exam too, it's good that the cremasteric reflex was present on both sides, because in a torsion it would be absent, or could be absent on that affected side.
Ah, okay, good. Okay, what's next, Whitney?
Can we palpate?
So, yep.
Oh, sure, go ahead.
Palpate the lymph nodes in that area. I didn't catch if we did that yet.
Sure. Yeah, that's a different thing. Let me. I gotta go to the abdomen. Hold on. There are small, non-tender, mobile inguinal nodes bilaterally. Is that normal? Okay. Okay, what next?
You could do a brief neuro exam just to make sure he doesn't have any ataxia. You probably would have noted it when he walked in the room.
Okay. Let me check here. Let's see here. Gait. Patient stands with no difficulty. There's no postural abnormalities or musculoskeletal abnormalities. No involuntary movements or abnormal movements. On walking, there's symmetry, right and left symmetry in the swing of the arms and in the movements of the legs and pelvis. Pelvis and shoulders are stable during walking, and placement of the feet on the floor seems controlled.
Great. So we can move to the GI exam. So as Shetha mentioned in our last session, you would definitely want to just inspect the entire abdomen first, look for any ecchymoses, any like battle or Cullen sign.
I'm going to share my screen with you guys again so you can actually see the abdominal exam from the case. So can you guys see that?
Yes.
So here's the view. On inspection, the abdomen is symmetric, skin is smooth without striae, venous pattern is minimal, there are no rashes, the abdomen is scaphoid without local bulges, no peristalsis, no pulsations. Umbilicus is small, inverted midline without signs of inflammation or hernia.
Good.
So you viewed the abdomen, now what?
So now you would auscultate in all four quadrants, or percuss first. Yeah, I'd auscultate first and then percuss.
Okay, so grab the stethoscope. We'll listen in the right upper quadrant. On auscultation, clicks and gurgles are heard 10 to 15 times per minute. Occasional what's borborygmi?
Like the sounds of the intestines.
Oh, so my stomach grumbling?
Hunger pains.
Okay. No hums, bruits, or friction rubs are heard. So let me see if it's any different looking at the other quadrants. Same thing in left upper, same thing in right lower, or left lower, and same things in left lower and right lower. Okay, so we've looked, we've listened, and now what?
Percuss.
Percuss. I can never remember. Here's percussion. So percuss right upper. Liver dullness is 6 centimeters in the midsternal line, 9 centimeters in the right midclavicular line. Area of dullness descends 3 centimeters on inspiration. Is that normal?
Yes.
Okay, we'll go to the left upper. On percussion, tympanic sounds are heard. You want to percuss right or left lower quadrant first?
Left, please.
Left. Okay. Tympanic sounds are heard on the left. On the right, dull to tympanic sounds are heard and patient grimaces to indicate tenderness. Why'd we all go, Was that a test of rebound tenderness that we were talking about, or was that the Rosting sign?
No, but no, it's not. But that shows that the patient has some guarding, and that it describes the quality of that pain.
It's pretty bad if he's having pain with just percussion.
Okay. So do we want to feel the abdomen then?
Yeah, but start with the right, do the right lower quadrant last.
Okay, so we'll start in the right upper and we'll move our way around. So upper right, there's tenderness on deep palpation of the tip of the 12th rib and a positive Chapman's reflex. What the heck is a Chapman's reflex? Looks like we got ourselves a learning issue. Okay. Gallbladder is not palpable. The liver edge is palpable on deep inspiration. It's smooth, non-tender. Slight referred pain to the right lower quadrant on deep palpation. There is no rebound tenderness. The left, no tenderness to light or deep palpation. Spleen cannot be palpated. Slight referred pain to the right lower quadrant on deep palpation. Left lower, no tenderness on light or deep palpation. Slight referred pain again, same thing. And now for the one we want, there's tenderness on light palpation and severe pain on deep palpation. No masses are palpated, questionable rebound tenderness present.
This is when you apologize to the patient.
Okay. So is there anything else in the abdominal exam we need to do before I want to go back to the differential diagnosis real quick? Is there anything else we need to do on the abdominal exam?
If the program can do a SOAS or an obturator sign.
That would have been as part of the movement. Let me see if we can. Sometimes there is. It doesn't look like, maybe if it's movement of the leg. Let me go to full body here. Hold on. Nope, it doesn't look like I can. So let me stop sharing here a second. Is there anything else on physical exam for the abdomen? Okay, let me stop sharing so we can all get back on the screen together here. Okay, so let's go through our list. So appendicitis, I guess that's still up on our list. Okay, what about pancreatitis? No, do we still need that amylase and lipase? Yes, no, maybe, no, yeah,
I
no,
would
yeah.
still get it as part of the work.
Okay, we can do it. Pancreatitis is probably really low, but we can get it. That's fine. What about Crohn's disease now?
You know,
No.
Jim, I'm so sorry, but is it too late to inspect the mouth for any ulcers? Sometimes those
No, we can do that. Hold on a
are
second.
associated with Crohn's.
Let me quickly look. The lips appear normal without ulcerations or cracking. Mucomucosa pink, moist, and without ulcers or nodules. So why did you want to know that? Look in the mouth for sores for Crohn's disease.
So there's an association with aphthous ulcers. Maybe some say it's due to the vitamin deficiencies that result from Crohn's. Some say it's just, they don't really know, unknown pathophys.
Okay. So does that mean enough we can cross off Crohn's? Or do we still leave it down arrow, like big down arrow?
We could leave it down there, just one less thing to support it.
Okay. What about constipation? No?
He would have had a lot of dullness to percussion all in all the quadrants. So
Yeah.
Take it off.
Yeah, and he just had a bowel movement yesterday. I think.
Okay. Kidney stones? No CVA tenderness. We still need that UA. Would that help convince the story? Okay, we'll leave it on, put it down arrow, but we'll get the UA just to make sure. Peritonitis, I guess that's related. So what's the difference between, are all appendicitis peritonitis or all peritonitis is appendicitis? It's sort of like, are all fingers thumbs, all thumbs fingers? I mean, is there a separation between these two?
Yes, definitely. So appendicitis can cause peritonitis.
Okay.
But there are other causes of peritonitis.
So how would appendicitis lead to peritonitis?
So if it perforated and then infected the peritoneum.
Based on our physical exam, we don't have labs yet. I know you guys want to get a CBC. Based on what we know physical exam, you think it's possible he has peritonitis?
I think his pain level would have been higher with more of those maneuvers.
Okay. What about epididymitis?
No indication on the exam.
Okay, exam was negative. What about STIs?
Same thing there.
Do you still want to do those cultures though, because it's a good screening if he's never had them done, or is it not indicated now?
I think it's still possible.
Okay, we'll do it.
I guess it depends. I guess maybe we should have asked this way earlier on, but where are we at? Are we in the ER?
We're in the ER.
Okay. I probably
it's always nice to know your setting. Yeah.
Yeah, I probably wouldn't do them in the ER, but I would say go to primary care and get these done. But if we're in primary care, yes, absolutely.
Okay. What about diverticulitis? Is that still on our list?
Yeah. Doesn't have to be high on the list, but it can be there.
Okay. Let's see. You wanted to get a CBC. Let me give you the CBC here. Let me cut and paste that for you so you can see it. So there's the CBC. You see anything abnormal?
There's leukocytosis, and no, actually that's normal.
That's not normal. Okay.
No, I'm saying the leukocytosis is abnormal. I was gonna say something about the bands, but that's 0. So.
Okay. And the neutrophils are up. When you, they did take a look at his differential, the peripheral blood, and if I can find it, I'll bring it up here. Okay. Let me share this screen with you. So there's what they saw in the blood smear. So what's that thing in the center?
A segmented neutrophil.
Okay, so and that's the neutrophils, the 66% on his differential. Then what are these things that I'm pointing at? What are all those things?
Red blood cells.
Okay, and then what are these little tiny things?
Platelets.
What are those?
Platelets.
Platelets, okay. So looks like his red cells look kind of normal. And if you look at his CBC, it looks like all of his things for his MCV and MCHC and all that stuff look normal, and his platelet count looks normal. So other than his white count being elevated, I'm going to stop sharing here. What does that white count elevation indicate to you? What's the possibilities?
Some type of infection.
Okay. So does that help us with the pancreatitis or the appendicitis or the kidney stones or the diverticulitis, or is it too nonspecific?
It really does help us with appendicitis.
How so?
A high white blood cell count is present in appendicitis.
Okay. Is that due to your body's response trying to fight off? So what's the underlying mechanism for appendicitis?
So there's, some sort of, so the appendix, right, is just some sort of like accessory thing that we don't know why it's there. And it's at the cecum, and a fecalith gets in, or something gets in, gets trapped. Organisms get in there, invade, inflammation, and that inflammation can lead to the white cell count, or it can be that the active infection leads to the white cell count. And then obviously if it perfs, then you have a bigger inflammatory response.
Okay. So the other thing you guys wanted lab-wise was the urine analysis, because you still had kidney stones on your list. What are you going to look for? If you're thinking kidney stones, what are you going to look for in this urine analysis?
Sometimes you'll see crystals.
Anything else?
The pH. The pH will tell us too.
Okay. Any other cells you might see?
Epithelial cells from like the sloughing.
Okay. So here's his urine analysis, and so it looks like his pH is okay. No protein, no bilirubin, no glucose, no ketones. 2 to 3 blood cells, 0 to 1 white blood cells, no bacteria, no epithelial cells, no casts, and I'm assuming no crystals since they don't mention them. So it looks like is 2 or 3 red cells and 0 to 1 white cells normal for an 18-year-old boy, or man, I should say. Okay.
Completely normal.
So does this eliminate kidney stones as an issue then? So we're crossing that off. So
and our urinary tract infection.
Okay. So we have, I still have diverticulitis on my list, Crohn's disease on my list, pancreatitis, and appendicitis. And I think for pancreatitis, you said you wanted the amylase and lipase. Why are those going to be helpful?
Because those are very, very good tests to see if if they're elevated more than 2 or 3 times the normal, that can be extremely helpful in you ruling in or out pancreatitis, and it's a blood test, so it's very simple.
Okay, so his amylase is 75 international units per liter, and I'll tell you that's within the normal range. And the lipase, I can find it, there we go. It says 9 international units per deciliter, and that is also within the normal range. So amylase and lipase are normal. So does that eliminate, when we add in his history, his physical exam, and now these labs, does that eliminate pancreatitis? Okay. So we're still stuck with diverticulitis, Crohn's disease, and appendicitis. And you guys also said, we were talking the other day, you were talking about a KUB, an abdominal x-ray versus a CT scan. So what would you do in this case? You're in the ER. What would you do next?
I feel like I'd go for the CAT scan, because I think we're thinking more so with appendicitis. So he's going to need that before surgery. Just thinking down the line, and why expose him to radiation more than one time. And the CT is what we're really going to need for that.
Okay.
Yeah,
So
I think KB definitely not useful with our differential that's left. But in terms of a workup for appendicitis, I've definitely seen people taken to surgery just with a white count and like a really positive physical. So I think in real life, like it could, or like textbook, you could take somebody to the OR with this physical exam and their white count looking the way it is, but in real life, like they're not getting to the OR within like 4 to 6 hours, so you have time to do the CT scan in the ER anyway. You might.
Okay.
So I mean, I think.
So you want the CT scan?
Can
Okay.
we do an ultrasound first and then do a CT if it's if the findings aren't like
Good point, Shetta.
Sure.
Just because less
Sure.
radiation for an 18-year-old boy.
Okay. His ultrasound. Come on. Ultrasound says there's no hepatosplenomegaly noted. The gallbladder is within normal limits, as is the common bile duct. No masses or abdominal fluid collections are noted.
The appendix is often not visible on ultrasound.
Okay, so at least we didn't expose him to any radiation. Let me see if there's one other thing on here. Hold on.
It could have been valuable though if it ruled out a perf, right? There would have been free fluid in the abdomen. So we know the acuity is a little bit less in emergence of getting him to the OR.
So do you still need that CT scan then? Okay, here's your CT scan. Sigmoid colon, bladder, and ureters are normal in appearance. The cecum is enlarged and there is a small fluid collection. What does
to the OR.
To the OR. Okay.
Isn't that a perforation if there's or an abscess around? Doesn't that suggest that?
I don't know. It says a small fluid collection. I'm not sure.
Oh, I think we would actually see air if it was a perforation, right? Because, yeah.
Can you show us the images, Jim?
It doesn't have the images, sorry. All I got is the words, so. Okay, listen, that's the end. You're going, okay, so that's the end of, we're running out of time here. So I had a couple of things on our things that we need to do for the next session. One, somebody's got to find out what Chapman's sign is. Nobody knew what that was. And then what I really want to focus on, and then the other thing was, is this CT scan, the cecum enlarged and small fluid collection, what does that really mean? And then our last thing that we're all going to work on is what we're going to do for Mr. Johnson now. You guys have talked about surgery, but I want to talk about, what is that going to entail? What do they need to do pre-op? What's going to happen to him during surgery? And I also want to focus on what's going to happen post-op with him if that's what you guys decide we need to do. So we'll, everybody can kind of look up. We've only got those 3 learning issues. Everybody can kind of look those things up. And then when we come back the next time, I really want to focus on the assessment and plan. What are we going to do for Timmy Johnson here? Sounds like he's going to go back to surgery after having had one yesterday. So poor guy, sounds like he's going to be operated on again. So next time we get together, we'll go through those things and then we'll wrap everything up. Okay? Okay, we'll see you guys next time. Dun, 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 dun. We move ahead in time. Wow, it's amazing how time flies here when you're having this kind of fun. And to be honest, you guys, don't put any of this in here, but I don't know what a Chapman sign is either. Do you guys know what that is?
No, I was Googling madly.
Yeah, I saw
some EKG thing.
Yeah, I think I might have looked up Chapman's, and that was like some sort of like trigger point stuff. So.
Okay, let me see. I've never heard of it before.
We bring out the trigger point dry needling in the ER and just have it. I'm just kidding.
Guys, I feel like I actually learned something this year.
Wait, what was it? Chapman's? What was it called?
Chapman's.
Was it Chapman's? Let me see.
Chapman's.
Let me go back to the
CHAPMANS.
What was it? CH?
AP.
Shetta put it in the chat.
MANS reflex.
Reflex. Because when you put in sign, it tells you something about the heart.
Mm-hmm. I think it has to do with the spinal nerves, the ends of them causing in the lymphoid tissue. I'm not sure.
These reflexes are noted. Good old Wikipedia. Shh, don't tell anybody that. These reflexes are located in the lymphoid tissue and the fascia and are manifested in the acute stages of soreness or tenderness in the distal ends of the spinal nerves. The tenderness is due to hypercongestion and is known as Chapman's reflex point. Wow.
Neurolymphatic points are found at specific areas that correspond to visceral dysfunctions.
Oh my God. Okay, we're not going to discuss this because one of the things that comes up is quackery in medical school, Chapman points. So I'm not sure I'm going to bring this up, okay? I don't want people thinking that we're doing it. Listed under osteopathic medicine, so I don't want to get into
That's what I just put in the chat. I bet you a DO wrote this case.
Yeah, so we won't touch on that. So, okay, so what we're going to do is come back. Amy, unfortunately, I'm going to let you again give the short presentation. You should have it memorized by now. And then we'll probably just spend 10 minutes or so on the assessment and plan. I'm not even going to go over the Chapmans or the CT scans. So you guys ready? Okay, you guys are doing great, by the way. And let me tell you, you've evidently learned something, because the hardest part with this was you guys are too damn smart. Play stupid once in a while, okay? My God. I'm trying to answer these questions. I'm going, okay, please don't know what this means. I mean, please tell me you don't know what this means. I know you know what it means, but you guys are just way too smart. So, okay, which is good. I'm not complaining. Trust me, I'm not complaining. This is great. Okay, so you guys ready? Okay, here we go.
Okay,
So,
we have 18.
Okay, so, sorry. We're going to hold on one second. I'm going to give a pause so that they can make some editing cuts here. Okay. So we're back again, you guys. Thanks. So let's start off by kind of reviewing the case again. So Amy, I'm going to leave it up to you again to tell us about Mr. Johnson, and then we're going to focus on the assessment and plan. So Amy, take it away.
Okay, we have an 18-year-old white male with recent onset of abdominal pain. This happened abruptly while he was playing tennis. It started in the left-right lower quadrant when it transferred to the right lower quadrant. Straightening up makes it better, bending forward makes it worse. He denies back pain. It is non-radiating, a constant pain that he's never had before. It's a 5 out of 10 pain that he describes as burning. He denies any constipation, diarrhea, vomiting, fever, chills, or weight loss. He admits to nausea, burning pain, and cramping. He eats healthy, drinks plenty of water, denies any alcohol, drug use, tobacco. He uses protection when he's sexually active and denies any sick contacts. We did some imaging. We let's see. His vitals are stable, and he has an increased white blood cell, increased neutrophil count. UA was normal, amylase, lipase, normal. Ultrasound showed no masses or no abdominal fluid. We did a CT scan, which showed cecum enlargement with fluid collection. He appears non-toxic, and upon examination of his abdominal, it looks within normal limits. Auscultation was within normal limits. We percussed, and we did get some dullness with tympanic sounds in the right lower quadrant. Upon palpation, his left lower quadrant had some tenderness with deep palpation. And then his right lower quadrant was extremely tender with severe pain with deep rebound tenderness possible.
Okay. Okay, good. So what do we think is wrong with Mr. Johnson?
I think he has a complicated appendicitis. I think it did perforate according to the CT with the fluid collection around the cecum.
Okay. Okay. So what do we do for him? I mean, does he go to surgery? Does he go, oh, we're going to snip him? Okay. So let's talk about his surgery. So what do we need to do? So let's kind of change our roles here a little bit. Let's put on our surgical PA hat. So now you're not the ER PA anymore, you're the surgical PA, and you're called to come down and see this guy from the standpoint of, you know, they've done all the ER PAs did the wonderful workup for you, okay? So now what do you have to consider from a preoperative standpoint? Is this guy gonna go to surgery in the next hour, next 2 hours, next 4 hours, tomorrow? And then if so, depending on that, what do we need to do for him for pre-op?
We need to probably start him on some antibiotics,
Okay.
so get that IV and make sure that he's NPO. So I think he started some antibiotics yesterday, but yeah, it's gonna have to be IV now.
Okay. So what's NPO mean?
That he can't eat or drink before surgery.
Okay. Okay. So you also said start him on. Does he need any IV fluids or just the IV antibiotics?
Yeah,
I'm gonna assess his volume status and see how he is.
Okay. Let's talk about the antibiotics for a little bit. What are you going to start him on? We're going to have an abdominal surgery. So what are you going to put him on? I mean, what's the possible, if you talked about that this is possible rupture or a complicated appendicitis due to the fluid on the CT scan. So what organisms do we have to cover?
Like anaerobes, so metronidazole and
Okay.
ceftriaxone would help with any gram negatives too that were in the bowel.
Okay. So metronidazole, you said, covers the anaerobes, and then ceftriaxone, or as I call it, vitamin R, Rosefin, will cover the gram negatives, you said?
Yeah, right? Yeah, gram negative.
So what organisms are we mainly worried about in gut flora?
E. coli.
What are the common gram negatives? E. coli, E. coli,
Klebsiella.
E. coli, and E. coli. Okay. So that seems pretty broad coverage. Now, it's been a long time since I've been in the operating room, but I remember giving everybody Ansef before surgery. Why are we not giving him Ansef?
He already has did he already take Keflex? Does he have Keflex on board at this point?
Yeah.
What
Would
is
the-
Ansef?
Cefazolin. You don't need to kill a mosquito with a cannon. I mean, you want to have good microbial stewardship. So what you probably would do is consult your hospital's like microbial guide, and it would tell you what you use for this particular situation because they know the susceptibilities in your area.
Okay.
If we were using ceftriaxone, I think that would probably cover gram positives enough. I mean, if we wanted to be extra sure, we could probably still do Ansef intraoperatively, but if we're doing ceftriaxone, if we were just doing like Pip/Tazo, we probably want to do Ansef as well. But I think if we're doing ceftriaxone, we can probably hold off on Ansef.
Ceftriaxone is a cephalosporin, correct?
Yeah.
Don't they cover anaerobes as well? Do I still need the metronidazole?
I don't think they have great anaerobic coverage.
Okay. So we'll add that. So what's going to happen to him when he goes to surgery? Oh,
Before
sorry.
we do any of that, though, we need to make sure that he doesn't have an allergy to any of these medications. Like, does he have a penicillin allergy? That might lead us to take that off the menu.
Let's check his allergies because we forgot to do that on the first day. Let's check his allergies. None. You guys dodged a bullet. Well, you knew he wasn't allergic to probably penicillins because they gave him Keflex. So
I never like to trust other providers.
No. I totally agree with you. You take your own history. I totally agree. But odds are, if he was allergic to penicillins, he would have reacted to the Keflex the last couple of days. So, okay. So we're going to.
Question. Are we worried about Pseudomonas at all because he was in the hospital recently? Like, do we need a cover for Pseudomonas?
What do you guys think? He was probably outpatient surgery for a couple of hours.
I don't think we need to cover.
We definitely need to.
Go ahead.
Oh, I was going to say, moving on from that point, we definitely need to consent him.
Okay.
And we should talk about pain control too.
Okay. Well, one of you guys put together this really nice diagram. Let me bring this up because one of the things I want to talk about here is the layers of the abdomen, and I'm not sure this is all going to show, so bear with me here, okay? So can you guys see that? So when we look at the couple of things that you guys, I don't remember if it was Aaron or somebody posted this. So the first thing in that diagram, it says there's the classic incision site, but what's this McBurney's point? Seems right where he seemed to have the pain. And it says 1/3 and 2/3. What are those landmarks there? I don't understand. I know what the umbilicus is, but what's the other landmark that they're pointing to?
It's 1/3 from the anterior superior iliac spine, and then 2/3 of the way from the McBurney's point. So if you draw a line, that's where his pain is, they said.
Okay. And this is this would be an open procedure. They can do this laparoscopically as well, right? Yes?
Yes.
Okay. So let's go to the next little slide, or the next side of that picture, the different layers of the abdomen there. I can tell you that when you get on your surgery rotations, this is something that they are going to pimp you on right and left. As you're cutting into the body, they're going to go, so what's this layer? What's this layer? What's this layer? So don't forget to, you've got all these different layers. And some of us have a little more fat, and some of us have a little more thickness of some of these areas than others. So let's not judge. And it looks like you've got to go through about 1, 2, 3, 4, 5, 6, 7, or 8 layers to get to the appendix. As you're cutting through those, how are you going to make sure? Don't you just cut through, or do you have to cut in different directions, or are you doing them all at once? How am I getting through this?
You cut, and then you blunt dissect, and then you cut, and then you blunt dissect. And
what do you mean by blunt dissect?
Using either fingers or like the end of like a clamp to push through and not incise, so you're not cutting underlying structures, especially when you're getting close to the peritoneum.
And you always lift the peritoneum up so that you can visualize it with the forceps, and then you use scissors to cut it. You don't ever incise it with a scalpel because you don't want to nick the small bowel underneath and cause yourself a whole other set of problems. Okay.
So I don't want to get through there's lots of videos out there you guys could watch on doing appendectomy, and I'm sure you'll see them in the clinical year. Let's talk about post-op. What are we going to do for this gentleman post-op wise? I mean, he's 18, he's pretty healthy, probably not going to have there's no comorbid conditions we have to worry about. So what's his post-op? What are you going to do as that surgical PA now for him post-op? When can he get up and move around? Do you need to continue those antibiotics? When can he go home?
No tennis.
He's going to love that. Okay. So what about his activity level? What can he do? I mean, how long is he going to be in the hospital recovering from this?
What time of the day did he come in?
This was morning. He had surgery that afternoon. He's back in recovery. It's around dinner time. He's back in recovery.
If he has return of bowel function, he can probably leave by the evening, assuming not an uncomplicated course.
Oh, wow. Okay. So what does he need to watch for at home then?
Fevers, redness around the incision site, any, purulent discharge, new onset pain somewhere else, if he has a rigid abdomen, if the incision's bleeding or something like that.
Okay. Okay. What about these antibiotics? Do I need to continue those after he's sent home? Do I just keep giving him the IV metronidazole and ceftriaxone?
I think you can give it to him outpatient for 3 to 5 days.
Okay. Okay.
Probably depends what you find intraoperatively too. If there was an abscess or a perf, like you're going to continue those longer than if you just if it's a clean appendix and you cut it out.
Okay. So if he perforated and has stuff in his peritoneal cavity, is he going to go home that next day, or is he going to be sticking around a while? So what are the key things we look for before we can send somebody home post-operatively? What are the things we want to make sure they're doing or being able to do?
Well, we want to make sure that their white blood cell count went down, that they had a bowel movement, that they're able to eat normally without any nausea or pain or vomiting.
And ambulate.
And ambulate, yeah. No good to send them home if they can't move. Okay. So the last thing I want to talk about here is pain management. So he was given Tylenol with codeine for his septal surgery. Can we just continue the same thing with him? Does he need OxyContin? Does he need morphine? What are we going to do for pain management, and for how long?
I wonder how much of the pain medicine he did use. If he was playing tennis, he might not be in that much pain, so it might be a good option.
Okay.
You could give him 6 to 8 more tabs of, the Tylenol 3 if you tolerated it fine, but no more than that. And I very strongly advise them about, the potential for, misuse of opioids anytime you prescribe that to a patient, but then just Tylenol and ibuprofen, honestly. His pain should be controlled. You can use them.
Let's say we were going to give him Tylenol with codeine like they did post this nose surgery. How often do you take Tylenol with codeine? Is it like every 4 hours, every 6 hours? What's the frequency? Every 6 at the most?
40.
So if we did it every 6 hours, he could take up to four doses a day. Is it 1 tablet, 2 tablets? What is it?
Depends on how you write it.
Okay, well, what would you, this is a young guy, he's 18, otherwise healthy. You think 1 will be enough? Okay, so if he does 1, he would be doing 4 pills a day. Shouldn't we give him like a month's supply of Tylenol with codeine, 120 pills? Why not?
That's how you get an opioid epidemic, Jim.
Oh, so you only give them the number of pain pills they need for the duration. So I give them, you said give them 6 to 8 pills. Let's say we give him 6. After he's taken those 6 over the next couple of days and he has more pain, what is he supposed to do?
That's why I wanted to give him Toradol. It's an NSAID. I just feel like we can avoid giving him opioids altogether, and it's pretty effective.
I mean, we also cut into his stomach for a perforated abdomen. So I mean, if he's in pain and he wants to take an opioid and he's okay with that, because some people aren't. I mean, some people just don't want opioids. But I mean, we did him. This is not an insignificant surgery, and Toradol is only IV, right?
Or IM.
Or is it IM? Nice.
You can give it IM too.
Yeah.
But still, he'd have to be taking shots at home then, so that might be a little difficult. Might have been good post-op, but it might have been a little difficult for home.
He's also going to be following up with us outpatient. Like, hopefully he's following up with the surgical clinic outpatient, so we can check it in a week or 2.
Okay. So it sounds like there's a lot that goes into pain management. It's not just a routine. Oh, it does have PO dosing. Okay. So it doesn't sound like there's just a routine, you know, you've got pain, we give everybody morphine or give everybody OxyContin. Sounds like there's that more goes into it. It sounds like it's really something you do in discussion with the patient, coming to an agreement. Oh my gosh, it's like shared decision making. Wow. Okay. So we send him to surgery. He recovers nicely, and that's about all there is for this guy then. So
you need to give him his activity restrictions. You make sure he's not doing any heavy lifting more than 15, 20 pounds for a couple weeks, because you don't want him to blow through his sutures and end up, with a hernia.
He has one question for you. When can I start playing tennis again?
I actually don't mind him playing tennis as soon as he wants to, so long as he's not straining super heavily. If he wants to hit some balls, that's fine. I mean, I would say even in a couple days, as long as he can tolerate it, but I would say no like vigorous activity, lifting, or, for maybe 4 or 6 weeks. Okay,
so you don't want him playing competitive singles or doubles. Okay.
Leave the Olympics for the next year. How about that?
Okay. That kind of wraps up everything, you guys. That was fantastic. We will see you guys then again the next time. Okay. Thanks, everybody.